The next speaker, yesterday evening, left the party, and I said, Gregor, there are many rumors about you. Can I tell one of them the next day? And he's like, yeah, whatever, I'm tired, I go home. And I see he's now very nervous that what I will say about him. But I won't. Gregor Hočevar is probably the name I say the most in my pitches to new customers, because I was so impressed by his cases in the aesthetic zones, how he can let the soft tissue grow. He has done his studies in Ljubljana in beautiful Slovenia. Go there and visit him. It's an incredible destination. He has also been named best graduate, not once, but twice, with 2 famous prizes in his hometown. He has done a postgrad in Germany and Switzerland, and he speaks actually fluent German. But the funny thing is, and now you have to listen, maybe you have to say something afterwards also. The funny thing about his German is you won't realize this speaking English, but he has Arnold Schwarzenegger's dialect. So really? You have an Austrian accent.
Yeah, that's right.
So you're truly a master. We are happy to have you here, and I won't say any rumors about you. You will talk about your prosthetic approach. He has done this lecture a couple of times also with us in Davos, for example, in front of titanium people, and it always earns you a lot of respect also outside of our group. And Rebecca, one question. He famously said something. He's an athlete, of course, also. I forgot to say that. Oh, and you're a good dancer. You told me not to say that. He said one famous quote, how is his pulse when putting an SDS implant?
You said you have a pulse of 45 when you work with SDS, and this is also an argument that you use to convince other people to start, because that's healthy too.
Yes,
you have a low pulse.
It is.
That's
like a
true.
reptile.
I mean, relaxed. Do you hear me? Is it
yes,
on?
we hear you. Thank you very much, Gregor Hočevar.
Hey,
the stage is yours.
Thank you. Thank you. Hello, everyone. I'm very happy to be here again. So last year, it was about organizing an event. I had this lecture, so it was not really my topic. But today, this is my home. So I will talk about ceramic implants and prosthetics with the subtitle, Aesthetics, Biocompatibility, and Function in Everyday Clinical Practice. So what exactly are we referring to when we speak of dental implants? So I get patients like this. They come to my office. We remove the crowns. We take the teeth out. We place some implants. And on top, we place the crowns. So this is actually what we do, what I do mostly every day. But actually, does the patient really care what we do and how we do it? They come to our clinic because they want to have the extraction of an infected teeth, like here, the first incisor. We can do this, we can place the implant and the crown, and they leave. Or maybe they come because they had an accident like this one, a boating accident, a really severe one. So this tooth was missing, tooth was a problem. So we can deal with it, we place the implant, and that's it. But actually, from the patient's perspective, does it really matter where the implants are positioned, how they are inserted, freehand or navigated, what they are like? Do they care if we place like one-piece implants or maybe two-stage, two-piece? We should say two-stage here in SDS language. I think that they don't care. They just want to have something that will replace the gap. So that's it. It's not about the implants. It's about the crown. So, and with the, so what would be the options that we actually have? We can do nothing, which we will not. So we can do something like a temporary. We can use the Invisalign or a ClearCorrect template, put some composite inside. Or we can fabricate like a removable denture. So these are more like temporary solutions. But of course, we can also go for definitive ones, like, for example, a bridge. I used to do tons of bridges. Now I would not do it anymore. You know probably why. Because to fabricate a bridge, you must grind two mostly healthy teeth. And by doing that, you reduce the longevity of the teeth. And we want to have like vital teeth in general. So that's why I was really, in the last years, I was really focused on dental work of the patients that were referred to my clinic. And I was checking what they had in their mouth. A lot of veneers, a lot of bridges, a lot of big fillings. And I noticed that it was not all good, because mostly but in general, the dentists, they are too aggressive. They grind the teeth, they place veneers because the patients, they want to have a perfect smile. And from the biological point of view, I don't want to do that. So I'm really becoming conservative. And that's why, in my eyes, I will come to this later. So just in between, this is, for example, one patient who came to my clinic to remove this root canal treated tooth and to clean the cavitation. And she wanted to replace the crown on the tooth for 6. And the tooth was sensitive, it reacted to electricity, to cold. But when I removed the crown, I immediately saw what was beneath, some remnants of mercury and the color. The color, when I see the color like this, I know that this tooth has no chance. Maybe it's still vital, but it will become necrotic. And if I have a tooth like this, I tell to my patient, listen, I think that this tooth needs to go out, although it's still vital. But when I cut it and I see no blood, then she has to pay. Whether I cut it and I reach the blood, then she gets the implant for free. But in most of the cases, they are already like this one. When I cut it, there is no blood flow. It's actually necrotic already. So, and no pathology was visible either on the panoramic or on the cone beam. So you really need to be careful about retreating with crowns these kind of teeth. So could be already like a dead tooth. So that's why, in my opinion, to replace missing teeth or to replace infected teeth, the best option that we have now is to place zirconia dental implants. And with the knowledge and experience in biological, very good dentistry, so we have the knowledge of minimal invasive treatments. We can preserve soft and hard tissue. We can use of biomaterial. And we assess the patient's immune system. And with the SDS implant system, we go from A to B. We are really straightforward. We do the immediate implantation. We do the immediate loading. After implant is integrated, we place the crown. That's it. And in most of the patients, the final outcome is even better than the initial state. I will show this. So today I will talk about ceramic implants and prosthetics. I will cover 3 areas: biocompatibility, function, and aesthetics. Biocompatibility. What does it mean regarding dental implants? So it means that an implant must integrate successfully not only with the bone, we are talking mostly about also integration, but it needs to get integrated also with the soft tissue, which ceramics does. And it needs not to provoke any toxic, immunological, or inflammatory response. So this is the definition. And if we place, of course, SDS ceramic implants, we are placing zirconia dioxide. It's bioinert. So we get excellent also integration. The soft tissue response is great. The mucosal seal is there. There is no biocorrosion, no allergy reaction, non-conductive. What does it mean? It means that it does not interfere with magnetic fields, electromagnetic fields. We have low bacterial adhesion. They are strong and durable. We have a long-term biological safety. And they're white. They are aesthetics, so no discoloration within the years. So if we talk about biocompatibility, we also must mention biomaterials. You all know PRF, APRF, IPRF, the blood concentrates. So I use two machines. One is set for the APRF, the other one for the IPRF. And that's why I get both, the best out of both fractions. I'm a huge fan, you mostly know, of collagen. So I use it ton-wise because what does collagen do? It enhances the bone strength in the sockets and gaps, especially in the gap between the ceramic surface and the buccal bone. A lot of studies saying this, and it's resorbed by the body after 4 to 6 weeks. So I use a lot of it. I will show you later on. So if we talk again about biocompatibility, we can transform our patients out of this situation with a lot of metal, different metal in the mouth, wearing like a denture and then some crowns, metal crowns on infected teeth. So we want to go from upper situation into the lower one. We need to place some implants, okay, zirconia one, and on top we place ceramics. So that means biocompatible. Another case, also infected tooth, porcelain fused to ceramics, a lot of material, a lot of metal in the mouth. So, and we can solve this as well. Okay, so now let's go to function. What does function mean regarding dental implants? So it means that an implant needs to replace a natural tooth in a safe and durable way, and it needs to perfectly restore the bite, of course. So then some question can arise whether which implant to place. So in my hands, it's very simple. In the aesthetic zone, which means up to the second premolar, I use the one piece. At the back, I use the two-stage implant. So that means provisional crown up to the second premolar in general. Secondly, the question arises how many implants to place. Of course, the tendency is to replace the teeth individually. That means that we can stimulate each of the organ. What do we do by that? We support the longevity, you know that. So that means 4 in each quadrant, 8 in the upper jaw, 8 in the lower jaw. But unfortunately in Slovenia, not everybody can afford 16 implants, for example. Then I need to go into some compromises. And I treat every year a few of the patients like this. So I place, especially in the lower, I place 4 implants, 1 piece, then the removable denture, the locator system, and it functions very, very well. I think that yesterday there was a question or discussion about cleaning. So also for elderly people, this is very easy to clean. They take it out, wash it, and it really functions well. So the oldest patient is like, I think, 8 years already is wearing this kind of solution. So it's a compromise. But of course, mostly the patients, they want to have fixed restorations. And when we talk about fixed restorations, we need to be really precise about the planning, implant placement. So the implant placement, the surgery needs to be prosthetically guided. What does it mean? So when we place the implants, we need to visualize, or we have a template whatsoever, we need to visualize how the crowns will look like, okay? So we go step back. I show it once more. And then we can place the implants really in the ideal position. And I seldomly need to grind them just after the surgical procedure. I want to leave them like this because I want to check the primary stability after 3 months. That's why I don't want to grind them when I do the surgery. So when we talk about the function, so I mentioned already, we talk about the bone, we talk about the soft tissue. Soft tissue is very important. And regarding implant placement, I will show you this in the video. We need to place the implant in the right position, in the right place, use some biomaterial. And because in most of the immediate implantation cases, I do not flap, I do not raise the flap, that means that I work open healing. And open healing, I started working open healing like 6 years ago. In the front, in the back, I position my implant in the desired optimal central position in the molar region, in this case, balcony one. I do not graft, I mean graft. I use PRF and collagen, that's it, no membrane, nothing. I just stabilize the material with the sutures, and this is what I get afterwards. And then I place the crown, easy. So, and of course, we need a good soft tissue. Soft tissue is a bit neglected, but it's as important as bone. And what can we do? We can play a bit with the soft tissue, not cutting it or whatsoever. We can position the implant in the right position, use the right biomaterials, and what can we get? We get the soft tissue creep. I will show you immediately. So here you can see just after the surgery, implant placement, immediate placement, provisional crowns. This is the biomaterial. I do not suture anymore. And you can see within one month, we get new soft tissue. And this is what happens in most all of the cases that I treat. It can happen also at the posterior area, the same. I extract the tooth, place an implant immediately in the central position. I used to go palatinally, but now I go in the center, perform the small sinus lift, and that's it. And then the crown. And you can see we can generate or guide the body to grow new soft tissue. I play a bit, I like some gadgets, I improvise a bit, and this is also very nice, what I do in late implantation. I take the SDS disc abutment, which has normally 2 wings, but I modify it, I cut one side of this disc, and I place this side on the outside so that I can press the soft tissue down. Otherwise, the soft tissue goes up. And what can I generate by this? You see this perfect soft tissue, keratinized soft tissue, that will support the underlying crestal bone. It's a simple trick. It's done in 1 minute, and a big, big result. So now, let's talk about the third area. This is the aesthetics. And I must say that in most patients that I treat, the final aesthetic result surpasses the initial state. In other words, if I have a patient, for example, like this one, with this ugly crown, it is a root canal, broken root, I'm able, with a special technique that I will show, only in one surgery, I can go from here to here. So that means that it's obvious that the aesthetic improvement is great. So this is a short video. Maybe some of you already saw it, but it's related to the new aesthetic line that will be shown right after that. So for example, this tooth needs to go out. I extract it, minimal invasive with a rotation in order to preserve the buccal bony lamella. Then I clean the socket whatsoever. Then I place the PRF matrix inside, and then the implant. And I came up with this idea to take an oval one, which was designed for the premolars, and placed it here because I wanted to create a gap because the tulip was in a way. And this gap is then filled with collagen that I biologize. I put some IPRF on top. And then I place the provisional crown, which does not, I don't want it to interfere with the soft tissue. It needs to be reduced. Of course, bonded to adjacent teeth, put out of occlusion, and then you can see this soft tissue creep. It happens in most of the patients. After 4 or 5 months, we remove it, we check the implant, we polish it, we scan it, and then we cement the crown. Very straightforward, easy. And Dr. Foltz kind of was upgrading this idea of getting away of the tulip. And here you can see, so these are Ilian, Robert, Ulrich, and me. This was SDS ambassador meeting in Croatia, Kornati, last September. I organized it, but only we four were there. And there Ulrich presented this new aesthetic line with this philosophy going away from the tulip and mimicking the anatomy of the front teeth. And so they look like this. This is the design, the aesthetic line, or the so-called TR, triangular shape. And I had this chance, in a way, to place two of them just last week on Tuesday. So this was the patient, and I was really nervous, focused. I did not have the Pulse 45 because I was so into it. So I extracted a few teeth, placed some implants, and those two, they were like, or are, triangular, the aesthetic line. So I was really nervous, so my picture was not so sharp, but you get the point. So this is like labelly, the tulip is reduced, and then it goes like this, triangular, like the anatomy, the cross-section of front incisor. And I know that the result will be really amazing. Because even when I placed the oval ones, a lot of time the mesial and distal side was too wide, and then I cut that away as well. So this is then the provisional, like I said, biomaterial. I just leave it like this. I reduce the gingival area of the provisional crowns. Normally I don't suture it. I just placed one suture there, and that's it. Okay, so I would like to, for the end, talk about the key factors influencing the aesthetic success. So you must already know that the surgery is really important. This was shown in the video, how to extract, how to place the implant, how to provisionalize it. So this is okay. But also the prosthetics is being in a lot of cases neglected. It's also very important, the prosthetical part, because we need to transfer the intraoral situation to the dental lab. And this needs to be exact. That's why I love scanners. I scan like for 9 years. And I would really, for those who don't use it, go for the scanner. And for the dental technician, he needs to get all the information, because otherwise something could go wrong. You will lose the implant, and you don't know who will be responsible. So you give the dental technician all of the information. Especially important is the gingival part. So, and it's of course a teamwork. You're not alone, you need dental technician. So this gingival part is very easy to handle with the SDS system, because we can determine ourselves where to place it and how to place it. It's very easy. Like in this case, I will show you some of the first incisors. So we can mimic the outline, the anatomy of the adjacent front incisor. Within minutes, we can copy the outline. It's very simple. So like in this case, or for example here, we can look how the adjacent tooth looks like, and we can copy it into the tooth. So here, a few of the examples. And this is, if you see the outline goes like this, I do it with my burr exactly the same. And for the dental technician, it's really simple. If I give him this kind of scan, he just needs to copy the other tooth and to place it inside. Not a science fiction or rocket science. So we go from here to here, and nobody will notice that we are working here. So now a few cases, a few patients. So this is one, for example. And you see in all of the situations, we get a bit of the soft tissue creep. I go also into very compromised cases with missing buccal bone, like in this case with the two laterals. So I place implant when I get it primarily stable. And you can see here, this is almost how many, 18 months. So this one and that one. And you can see if I really see this thick soft tissue, then I can have an easy sleep, because I know that the soft tissue will protect the underlying crestal bone. Okay, so today we talked about biocompatibility, function, and aesthetics. But what I do, it's not only about placing implants. It's about transforming the patients out of loaded, stressed, infected, distorted oral cavity, loaded with infections, with mercury, with some metals, titanium implants, also missing teeth, into relieved and healthy oral cavity. So this is, in a way, my mission. So we want to shift the patients from here to here. Of course, we use dental implants, SDS. We use some biocompatible material, and we need to restore the bite. So this is kind of my mission. Dental implants are a small part of it. So we move the patients from here to here. That's it. Thank you.
Thank you very much. Gregor, you could dance off the stage, actually.